Welcome to Hematology Case Scenarios Part 7. In this module, let's look into the cases pertaining to regulation of erythropoiesis, hemoglobin synthesis, types and structure. Case 1. A 42-year-old premenopausal woman has emphysema, due to which she has impaired ability to oxygenate her blood. She experienced significant fatigue and tiredness due to hypoxia. She is admitted to emergency and administered supplemental oxygen when she was extremely breathless and incapacitated. Before the oxygen administration, the complete blood count showed red cell count of 6 million per cubic millimeter, HB 7.6, hematocrit 54. After receiving oxygen for several months, red cell count dropped to 5 million per cubic millimeter. There's concomitant decrease in the hemoglobin and hematocrit as well. Question is, which of the following is the reason for the fall in the red cell count following oxygen therapy? Options are reduced secretion of erythropoietin, reduction in ferritin level, increased erythrocyte survival time, increased red cell fragility. So if you look at the case, this is a case of chronic pulmonary obstructive disease, COPD, and emphysema with changes in the lung parenchyma impeding the oxygenation. She has hypoxia. So, in addition to symptoms of emphysema, respiratory symptoms, her red cell count is high, 6 million. Hemoglobin is high. Hematocrit is also high. And these parameters reduced after oxygenation. So, we had to argue, or the logic is, the oxygenation must have reduced the counts and the hypoxia must have increased the count because 6 million is above normal. Hemoglobin 17.6 is above normal. Hematocrit 54 is above normal. They all come back to the normal values. So the oxygen must have done the trick here. So we have to argue why the fall in the red cell count. It is not the real fall, it is the normalcy. So the counts have come to normal. So oxygen therapy has normalized the values and of course relieved her symptoms also, little bit of symptoms, but that's not our question. Why the red cell count has reduced? So hypoxia stimulates, all of us know that hypoxia of any kind, tissue hypoxia, maybe hypoxic hypoxia or other types of hypoxia, reduce the oxygen tension in the tissues. Reduce oxygen tension, hypoxia, tissue hypoxia stimulates kidney to stimulate erythropoietin. Erythropoietin secretion will increase RBC count acting on the bone marrow stem cells. So now what has happened is the hypoxia is relieved. The stimulation to the kidney must be less. So erythropoietin secretion has reduced. So high count has reduced to normal count. So it must be the reduced secretion of erythropoietin. The other options are not correct. Reduction in ferritin level, there is no indication of those ferritin here, and deficiency is not here. Survival time is not a correct option. Increased erythrocyte survival time of oxygen therapy is not correct. Oxygen therapy does not influence the erythrocyte survival. Increased red cell fragility is also not correct because oxygen does not cause any change in the fragility of the RBCs. So the correct option is A. Case 2. 40-year-old man visits a clinic complaining of chronic fatigue. He has been treated for an infection. Lab report, initial lab report, RBC 1.8 million, hemoglobin 5.2 grams, hematocrit 15, WBC 7,600, platelet 320,000. And look at the reticulocytes, 24%, MCV 90 femtoliter. So after the other investigation, the hematology suspects a hereditary red cell enzyme deficiency in the patient. Question is, which of the following is the most likely cause of the high reticulocyte count? This is a very obvious case where there is anemia, severe anemia. 5.2 is quite a marked anemia. RBC 1.8, hematocrit is 15%. WBC count is normal, platelet count normal, but reticulocytes are increased. So anemia with high reticulocyte count must be hemolytic. MCV is just above normal, doesn't matter. Reticulocyte count is the major thing here, and with anemia, severe anemia. So it is a hemolytic type and a red cell enzyme deficiency. The options are erythropoietin deficiency, excess hemolysis of red cells, vitamin B12 deficiency, or drug used to treat infection. Which of the following are the causes of the high reticulocyte count? As we have already seen, this is anemia with the high reticulocyte count. It must be hemolytic anemia. So B is the correct answer. Excess hemolysis of red cells. So there is severe anemia and stimulation of the bone marrow by erythropoietin secretion. So there will be no erythropoietin deficiency, there will be high erythropoietin. The RBCs are destroyed at a greater rate than production. So this causes hypoxia and erythropoietin secretion. B12 deficiency is unlikely because there is no indication of that. MCV is near normal. Drug used in treat infection, there should be a pancytopenia, reticulocyte should be reduced. It's a classical case of hemolytic anemia. Case 3. A 65-year-old woman complains of dizziness and visual disturbances. She gives a history of recurrent venous thrombosis in her leg veins. She has a ruddy complexion and skin shows cyanotic tinge. Lab values RBC 8.5 million, hemoglobin 21 grams, hematocrit 60%, plasma osmolarity 295 milliosmoles per liter, arterial pH 7.4, arterial PCO2 97%. Bone marrow biopsy shows hypercellularity with an abnormal excess of blood cells in the bone marrow with an elevation of red blood cells, white blood cells, platelets. Which of the following is a cause of polycythemia in this woman? So polycythemia is very obvious by these counts: high RBC, high hemoglobin, high hematocrit, osmolarity is normal, pH is normal, PO2 is normal. There is no stimulation. It is not secondary polycythemia. It's a primary polycythemia with the abnormal increase in all types of cells. So it must be something to do with the bone marrow. So we have already come to the conclusion a little bit. We narrowed down the options. Let us see. Hyperosmolarity. The osmolarity is normal. Hyperosmolarity does not cause any change in the cell count as such. Hypoxia, there is no indication of hypoxia. Arterial PO2 is normal. So it must be a primary bone marrow defect. Renal dysfunction, there is no indication of renal dysfunction here. And renal dysfunction will cause anemia and not polycythemia. So it's primary bone marrow defect, polycythemia vera. So this is called primary polycythemia. Secondary polycythemia is due to some other causes of which increase the bone marrow activity, secondary to some other cause, not the primary defect, like hypoxia, high altitude. Some other causes of hypoxia will cause secondary polycythemia. This is primary defect. Case 4. A 32-year-old man who has hypertension is diagnosed with polycythemia, another case of polycythemia, vera. On further investigation, blood counts RBC 6.2, hemoglobin 18.6, hematocrit 57, WBC 13,300, platelet 4 lakhs. Blood counts indicate polycythemia. His arterial oxygen saturation 97, so it is again a primary polycythemia. PCO2 is normal 40. Creatinine is normal 0.7 milligrams per deciliter, so kidney is normal. Plasma erythropoietin level is significantly low. Look at this. So that means it is not secondary polycythemia. It is a polycythemia vera already given, the diagnosis is given. Now question is, which of the following has caused the erythropoietin level to fall in the plasma? Why the erythropoietin is low? Decreased stimulation of the kidney, excess intramedullary destruction of red cells, renal dysfunction, folic acid deficiency. So there is a primary defect in the bone marrow, as we have seen in the previous case, excess stimulation of bone marrow activity, increase in the number of cells. So this will cause decreased erythropoietin by decreased stimulation of the kidneys. So kidneys are less stimulated because there is no hypoxia. Cells are more. The erythropoietin level will come down because of feedback regulation. So that is the answer. Decreased stimulation of the kidney. Excess intramedullary destruction of red cells occurs in B12 deficiency. It causes anemia. Renal dysfunction again causes anemia. Folic acid deficiency causes anemia. Here is polycythemia. So decreased stimulation of the kidney by a primary defect in the bone marrow. A case similar to the previous one. Case 5. A 50-year-old man has mild jaundice and weakness. He is found to have pallor and splenomegaly. His hematological parameters showed HB 11 grams, hematocrit 32%, MCV 77 femtoliter, MCH 28 picograms, MCHC 36%, WBC 13,400, platelet 290,000, RBC 4.2 million. Peripheral blood shows anisocytosis and spirocytosis. Which of the following statement regarding spirocyte is correct? So here is a case of anemia with the spirocytes in the blood. It's called spirocytic anemia. Spirocytes are large spherical RBCs. The blood film shows anisocytosis. That means cells with different sizes and shapes. Poikilocytosis must be there. So blood counts are near normal except a little bit of fall in MCV. Borderline anemia. Reticulocyte count is not given here. Anyway, which of the following statements regarding spirocytes is correct? They hemolyze less readily than normal red cells in hypotonic sodium chloride solution. Lifespan is longer than that of the normal red cells. They are trapped and destroyed in spleen at a rapid rate. Their membrane skeleton is more stable than that of normal red cells. So spirocytes are abnormal RBCs. They are easily destroyed in circulation. Therefore, and they are having a greater tendency to get hemolyzed in hypotonic solution. So A is not the answer. They are more readily, their osmotic fragility is more increased. They're more readily destroyed or hemolyzed in the hypotonic solution. A is not the answer. Lifespan is not longer. There is less. Spirocytes do not last long as normal red cells. Their lifespan is less than 120 days. C is the correct answer. Trapped and destroyed in the spleen at a rapid rate. The membrane skeleton is less stable. There is a problem with the membrane skeleton. Let's not go into the details of that. But red cells having spherical shape do not last long in the circulation. They also do not carry oxygen as good as the normal RBCs because their surface area volume ratio is less. They're more spherical, not biconcave. So oxygen carrying capacity is reduced. So there is some amount of hemolysis here. This is not very evident in the case because the blood counts are almost near normal except hematocrit hemoglobin borderline reduced. So there is some anemia. So chronic spirocytic anemia. Because of the hemolysis, there is mild jaundice and of course weakness of anemia. He is having pallor and splenomegaly because the spleen is at a greater rate destroying the large number of spirocytes, splenomegaly, enlargement of the spleen. So it's again a case of hemolytic anemia. So the reticulocyte count must be increased, which is not given here. Case 6. Hemoglobin concentration and hemoglobin electrophoresis were performed on a healthy mother and her newborn infant as a part of the screening program. This is unlikely normally, but let us take it as the truth. Mother's HB is 13, infant's 19, and there is 97% HbA. HbA2 is 2%, 1% HbF in mother. Newborn has 88% HbF, 12% HbA. Which of the following statements regarding HbF is true? HbA is fetal hemoglobin. Fetal hemoglobin in mother is only 1%. It's normal. Mainly 97% HbA. Small amount of HbA. So mother's values are normal. Newborn again normal. Newborn has high reticulocyte count. High HbF. HbF is 88%. HbA is less and gradually it is replaced. In few months, a few weeks, the newborn's HbF is replaced by HbA. HbF is normally present in intrauterine light because SPF is designed to carry more oxygen in a hypoxic state in the intrauterine life. Now let us see the question and the option. Which of the following is the correct thing about HbF? The oxygen bound to HbF at any given PO2 is higher when compared to HbA. Amount of oxygen bound to HbF at any given PO2 is lower when compared to HbA. Oxygen binding capacity of both HbF and HbA is same, but HbF is more stable in circulation. HbF binds more avidly to 2,3-DPG compared to HbA. Now you have to look at the oxygen dissociation properties of hemoglobins, HbF and HbA. HbA, if you look at the oxygen dissociation curve of HbA, normal hemoglobin, it's sigmoid shape, whereas the oxygen dissociation curve of HbF is more hyperbolic, parabolic shape. So that means at any given PO2, HbF oxygen or percentage saturation of HbF is greater than the percentage saturation of HbA. So it is a higher level. So that means the first question answer is correct. The amount of oxygen bound to HbF at any given pivot is higher. That means the curve is shifted to the left. Curve is on the left side. So second is obviously not correct. This is true of HbA. Oxygen binding capacity of the C is not correct at all. Stability is not the question here. It is mainly to do with the oxygen binding and dissociation. Now look at, if you look at the dissociation, 2,3-DPG, a compound in RBC, when it is present in higher concentration, it causes the oxygen dissociation curve to shift to the right. That means at any given point or PO2, there is more dissociation of oxygen from the hemoglobin. So since the curve is already to the left, at this is not true. HbF, the gamma chains, they bind less avidly to 2,3-DPG compared to HbA. It is beta chains. So at any given PO2, oxygen is more, percent saturation is more. So 2,3-DPG is increased in certain conditions of hypoxia, high altitude. So it will shift the curve to the right. That means at any given PO2, more oxygen is given out or less is bound. So this is a property of HPF, so ideal for intrauterine life. Case 7. A 24-year-old man has fatigue, severe back, chest pain. Started when he was trekking in a high altitude mountain range. He had similar episodes 5 years back on a similar visit, high plains. Hematological investigation revealed normocytic anemia with high reticulocyte count. A tentative diagnosis of sickle cell anemia or maybe sickle cell trait is arrived at. So there are several options given. We have to pick up the correct ones out of the 5. How are the abnormal hemoglobin molecules, that is HbS, in sickle cell anemia different? How are they different? HbF molecules, how are they different than the normal hemoglobin? Do they lack beta chains? Their presence makes red cells more resistant to the osmotic lysis. HbS molecules fail to unload oxygen tissues. At low oxygen levels, they polymerize. Presence of HbS prolongs the lifespan of red cells in circulation. So out of the 5, some are true, some are false. We have to pick up the right ones. True one. They lack beta chains. No, they have beta chains, but amino acid is replaced and they are abnormal. Lack of beta chains occurs in thalassemia. Decrease in the synthesis. Here, this is the case of hemoglobinopathy, where amino acid is abnormal or changed in beta chains. Second, their presence makes the red cells more resistant to the osmotic lysis. Yes, because these cells are more rigid. At deoxygenation, the HbS gets precipitated and the RBCs change their shape. They become more rigid and sickle shaped. So sickling makes the red cells more resistant to the osmotic. So second is correct. HbS molecule fail to unload oxygen. No, this is not correct. They load and unload correctly, but while unloading, when they become deoxygenated HbS polymerizes. That is 4. At low oxygen, they polymerize and RBCs become sickled. There is sickling at the deoxygenation phase. So RBCs are rigid. Fifth, presence of HbS prolongs the lifespan. No, sickle cell anemia causes rapid hemolysis. The abnormal cells are readily destroyed in the spleen. So there is anemia. Probably this in this case anemia was not detected. It's a sickle cell trait. The high altitude hypoxia has triggered sickling, and these sickled RBCs get accumulated and they may block the blood vessels, cause ischemia, and that may be the cause of this pain is got. Very common if there is a trait which is undetected disease. Sickle cell trait is more common than sickle cell anemia. Sickle cell anemia is more common in Africans. The persons is more resistant to malaria, they say. But here the question is about the molecules, hemoglobin molecules. So 2 and 4 are correct. Their presence makes red cells more resistant, their osmotic fragility is reduced, they are more rigid. And at hypoxia, at oxygen levels, low oxygen levels, they polymerize. 1, 3, and 5 are incorrect. So 2 and 4 are the correct answers.